Good afternoon. Welcome to EM Coding, Score Medical Decision Making the way an auditor does. Yesterday I was in the beautiful Southwest Florida waters and saw two bald eagles perched on trees swooping down, and we were in an area with lots of fish, and all you could think is he's waiting to dive down right next to us and scoop out something out of the water. It was so majestic to be able to see the beauty of the eagles and be in an area boating near them. But at the same time, they're a little intimidating. They are huge. You know, if you have a tiny little dog with you, you're a little protective. So it begs the question, you know, we can't be mind readers. We don't know what somebody else is thinking or what they're looking at. And when it comes to medical decision making, it's one of the hardest aspects of EM coding to be able to judge, because we can't get inside our physician's head. We don't know what they're thinking. And yet we have the responsibility, whether we are auditing or whether we're doing our coding in the office, to be able to make sure that the documentation clearly shows the effort that the physician was going through and is getting the proper credit for that. So how do we really do that without getting inside their head and without the physician having to write down so much material that it becomes cumbersome for the job that he's doing in being able to treat the patient? You can quantify your physician's medical decision-making level to protect your practice by using a risk management sheet. For those of you who've been on the call for our previous two series, we've been using the common standard risk management sheet that you can find from Highmark Blue Cross Blue Shield. And that's very helpful in being able to quantify the information that we're going to be looking at today. Navigating the sheet, however, can prove difficult. Here are some frequently asked questions to get you started. What is the table of risk? And maybe you've heard about this, people refer to it. It actually lives in two different forms. CMS published the table of risk as one of 7 tables in the 95 and 97 EM documentation and coding guidelines. So you can find it in both of those guidelines. Medicare providers are supposed to use the tables to calculate the history, exam, and medical decision-making types. The table of risk, which includes presenting problem, diagnostic procedures ordered, and management options selected, is one of 3 preliminary tables that you can use along with the problem categories table and the type of data table to determine the level of decision-making. The results of the history, exam, and the decision-making tables are then entered into a 7th table to determine the code level to bill. And we're actually going to do a summary problem at the very end that's going to show us how we can put all of these portions that we've discussed in the series all together. Other versions exist as well. The AMA published a version of the table of risk in 1999, and some carriers may have their own interpretations. Why should I use the sheet? And here's a picture of it. And we're going to be talking about these areas. We're going to be talking about the number of diagnoses or treatment options, the amount and or complexity of data reviewed, and then here's the main one right now that we're discussing, the table of risk. You should use the sheets because in the event of an audit, using the table of risk and the associated tables will provide support for your physician's code selection. You can also use the charts as a self-audit tool to check your physician's levels and make sure that you're on the same page. Use the original CMS scoring sheets when performing internal audits or selecting code levels. CMS does their comprehensive errors rate testing reviews using the 95 and 97 guidelines, not the carrier revised criteria. They made that determination about 2 years ago, so you can feel comfortable that your levels should match any kind of cert review that comes in to your practice if you're using these sheets. It's a really good safety tool. Watch out. You might have to use a different audit tool for some carriers. For instance, Trailblazer, which is the Medicare Part B contractor for Texas, Virginia, Maryland, and Delaware, has developed its own counting system. And you can get that from trailblazerhealth.com if you do need to have that. So how does risk tie into medical decision-making? Medical decision-making comprises 3 elements: number of diagnoses or management options, the amount or complexity of the data to be reviewed, and the risk of complications and or morbidity or mortality. To qualify for a given type of decision-making, whether that's straightforward, low complexity, moderate, or high, The physician must meet or exceed 2 of the 3 elements according to CPT-EM services guidelines. So why should I evaluate the type? And how can I do that? Well, since you can't read your physician's mind to figure out all the work he performed in determining a patient's plan, he can help you see what was involved by completely documenting the process. In the assessment, encourage him to include all the diagnoses and any suspected problems or concerns, including rule-outs. Now, I do want to have a warning here that make sure that you don't overlook that you will not be coding the rule-outs unless there is actually a sign or symptom in there that's being evaluated and there's no definitive diagnosis. But that wouldn't be a true rule-out when we're saying, ruling out cancer or rule out strep. You don't want to be coding that unless the strep test came back positive. You would be coding, if there was no better, more definitive diagnosis, the sore throat. But you would want to be going through and including the increased risk possibilities as part of the medical decision making, but you won't necessarily be using the ICD-9 code for those. And what should you look for in these notes? To weigh the type of risk, zoom in on 3 items. Identify each problem's diagnosis, status, the risk's treatment or management. You can map these to the CMS medical point-making system, which includes a table for the number of diagnoses or treatment options, the amount or complexity of data reviewed, the table of risk, and a summary scoring sheet. You can get the Highmark one that I referred to at highmarkmedicareservices.com. Now that we've walked through the audit tallying basics, see if you've got what it takes to score the following case of medical decision making using the standard CMS form. Let's try this example. An ENT sees a patient with a diagnosis of otitis media and decides the patient requires tubes. The physician orders no tests and reviews no records. The patient is scheduled for tympanostomy. In the table for number of diagnoses or treatment options, you must identify the problem status. To do so, follow these rules. If the ENT has previously treated the patient for OM, CMS considers the problem established and awards 2 points for an established problem that is inadequately controlled, worsening, or failing to progress as expected. If this is the first time the ENT is treating the patient for OM, you should consider the diagnosis a new problem, which is worth 3 points. Why is there a point difference? CMS expects that the decision-making for a known problem is less than that of a new problem.